common cold. In the past 20 years, there have been outbreaks with variant and novel coronaviruses causing more severe disease. In 2002, in China, there was an outbreak with severe acute respiratory syndrome coronavirus or SARS-CoV-2. It affected 8,000 cases and the case fatality rate was 10%. A decade later, there was an outbreak by Middle East Respiratory Syndrome coronavirus MERS-CoV in 2002 in the Arabian Peninsula. It affected 2,500 cases and the case fatality rate was higher with MERS at 35%. Now in 2021, we are in the middle of the global pandemic caused by severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2, which is determined to be a mutant virus of the SARS 2003. In other words, it is believed to be not a novel virus, but a variant of the original SARS 2003 virus. SARS-CoV-2 virus has caused 24 infections worldwide and has caused 48 deaths, 48 lakhs deaths with a case fatality rate of 2%. So one common question is, why do certain coronaviruses cause more severe disease? It is known that coronaviruses are zoonotic in origin, which means that they naturally reside in animal reservoirs. Sequencing and phylogenetic data supports the conclusion that many coronaviruses infecting humans have bats as their natural reservoir. In fact, we have solid data indicating that SARS from 2003 was transmitted from bats to palm civets, which served as an intermediate host for spillover of SARS into humans. Similarly, MERS virus is believed to be harbored in bats, but the initial transmission of MERS virus into humans occurred through contact with dromedary camels in the Arabian Peninsula. This very well explains why the MERS pandemic why MERS was restricted to only the Arabian Peninsula and have not shown a global spread to this point. And finally, while much less is known regarding SARS-CoV-2, it is believed that the virus was transmitted from bats to animals. Those were sold in the wet markets in Wuhan, China. Although the intermediate host for SARS-CoV-2 is still undefined, we have sequencing data that suggests that turtles or pangolins may have facilitated the transmission of SARS-CoV-2 to humans. Now that we have received some background information about the coronaviruses, SARS-CoV-2, let us turn our attention to the laboratory testing methods for COVID-19. Laboratory tests for COVID-19 can be direct tests detecting virus like RT-PCR or virus proteins like antigen testing and indirect assays like serology. To date, the vast majority of testing for COVID-19 has been performed using a technology called RT-PCR. PCR-based assays detect viral RNA in clinical samples and are designed to diagnose active infection with SARS-CoV-2. Antigen detection tests are cheap and they are highly specific, but the disadvantage is they are less sensitive. All the symptomatic patients who test negative on a antigen testing should be confirmed by a RT-PCR test. Recently, there have been a significant amount of attention on serology or antibody-based assays for COVID-19. This test detects antibodies like IgM, which rises from day 7 to 14 days of infection, and IgG, which can rise from day 14th and can persist for weeks, developed by the immune system in response to SARS-CoV-2 infection. Serological assays are unlikely to play a key role in diagnosis of COVID-19 due to the fact that it requires 10 to 14 days for antibodies to develop following infection. But serology will be an important means of determining whether an individual has been exposed to virus and has developed an antibody response. Majority of molecular real-time PCR tests have generally targeted a combination of the following structure and non-structure genes like the nucleocapsid, the open reading frame 1AB envelope, RNA-dependent RNA polymerase. Multiplex assays using multiple genes simultaneously or detecting different regions in the same target gene are used by various labs and they increase sensitivity. Coming to point of care RT-PCR test for COVID-19, there is About ID now. It uses a isothermal technology using proprietary enzymes at a constant temperature for the amplification of RNA. This gives results as early as 13 minutes. It is a very small and mobile instrument. There's another platform developed by Cepheid called Gene Expert Express SARS-CoV-2. This gives results within 45 minutes, but this is a costly test. CDC has classified variants as variants being monitored, variants of concern, variants of interest, and variants of high consequences based on how easily they spread, how severe their symptoms are, and how they respond to treatment. The genetic variants in viruses arise regularly and they can impact the PCR test and give rise to false negatives. Molecular tests with multiple gene targets are less impacted by these variations. In the background of variants, we should consider negative results in correlation with clinical observation, patient history, and epidemiological information. Repeat testing with a different FDA or ICMR approved kit having different targets should be used in the case of a false negative test in the presence of variants. These are the list of molecular tests which are impacted by the variants. As the primary clinical manifestation of COVID-19 is a respiratory illness, PCR-based tests generally used to test samples from the upper respiratory tract like nasopharyngeal swab or oropharyngeal swab. Or if there is evidence of lower respiratory tract infection or later in the disease, then we can use sputum, bronchoalveolar lavage, or tracheal secretions. There are several questions that are common with regards to molecular testing that I would like to address. First question being, there is growing amount of data in the published literature suggesting that the virus is present in peak amounts very early in the disease course. One recent study actually showed that the peak viral shedding occurs 24 hours prior to the symptom onset. This is very important as this likely explains why we have seen such effective community spread of the virus, since many people are shedding the virus at high amounts before they even know they are infected. Importantly, the viral load tends to decrease in the upper respiratory tract airway after 3 to 5 days. Another common question is, what is the sensitivity of a COVID-19 PCR test? Is it really 60%? At this point, it is important to understand that most clinical laboratories only know the analytical sensitivity of molecular PCR tests. In other words, labs have determined the limit of these assays using control material and known positive samples. The clinical sensitivity or the number of times the test will be positive in patients with COVID-19 still needs to be defined. The true clinical sensitivity of COVID-19 test likely depends on several factors, including when the sample is collected in relation to the disease course, the sample type, the quality of sample that is collected, and performance characteristics of the test itself. With regards to the sensitivity of PCR, there was a recent study published in the Journal of American Medical Association that assessed the detection rate of PCR using different sample types in hospitalized patients. The highest rate of positive results was achieved when testing bronchoalveolar lavage and sputum, but it decreased in samples such as nasal swabs and throat swabs. I think this data are contributing to the 60% sensitivity for PCR. Coming to the advanced techniques in molecular testing, we have digital PCR. In this, the template is isolated into single molecules by subdividing the reaction mixture into thousands of microscopic partitions. There is quantification without need for calibration curves. It has higher precision and analytical sensitivity due to partition of samples. But this is expensive, requires expensive consumables. It has a longer runtime. Isothermal nucleic acid amplification amplifies target sequence at a constant temperature without the need of an expensive thermocycler. The reverse transcriptase loop-mediated isothermal nucleic acid amplification allows identification of RNA sequences of interest. It was earlier used for SARS coronavirus and MERS coronavirus. It can detect the virus within 26 minutes as compared to the 1 to 2 hours taken by the conventional RT-PCR. CRISPR-based assays. They were initially discovered in E. coli. CRISPR-Cas system is a powerful tool for gene editing. The high sensitivity enzymatic reporter unlocking shell lock is based on amplification of target DNA or RNA followed by the Cas13 mediated detection using calorimetric and fluorometric readout is used in rapid detection assay for detection of infectious agents in clinical specimen. Excuse me. The SARS-CoV-2 DNA endonuclease targeted CRISPR transreporter detector assay consists of pre-amplification of E gene and N2 region of the N gene using RT-LAMP and subsequent cleavage of reported RNA by Cas12a and visualization by lateral flow strip or fluorescent reader. There is another CRISPR-based system which detects 100 copies per microliter of viral load of SARS-CoV-2 in 30 minutes using CRISPR-Cas13a and a mobile phone camera. It can be a rapid point of care for SARS-CoV-2. Coming to next generation sequencing. Next generation sequencing allows comprehensive characterization and analysis of viral genetic material. The major advantage is it can screen for and identify viral agents without the need for excuse me, previous knowledge of causative agent. Shotgun metagenomics facilitates detection of viral strains otherwise not detected due to highly mutagenic regions. SwapSeq is another method that applied NGS to diagnose SARS-CoV using unique molecular barcodes. But next generation sequencing is very expensive and it's time consuming and it requires highly skilled labor. To summarize, COVID-19 is continuing to cause a worldwide pandemic involving millions of cases caused by variant virus. RT-PCR is useful for acute diagnosis of patients with symptoms, and serology can be useful to determine exposure to the virus or not. Importantly, the sensitivity of PCR testing depends on a number of factors, including the timing of the disease, the test that is performed, the type of sample that is collected, and the quality of sample, and then the performance characteristic of the test itself. Thank you.
Thank you, Dr. Rakhi, for this wonderful overview of the various diagnostic tests, which you have very clearly discussed about the pros and cons and the timing of sample collection and the quality of sample, which is very, very critical in the PCR detection of the SARS-CoV-2. Well, as we all know that serology is not used for diagnosis, but there's only one addition I would like to add to the presentation is even IgA is a very early marker which presents in serology, and therefore not for diagnosis, but if suppose you want to just have a idea of whether the individual has been infected, then IgA and IgM both are a very good parameter, but even IgG comes very early. Thank you very much. And let's move on to Dr. Pooja, who's going to talk about COVID variants and recent advances in COVID diagnostics. I have had the privilege of working with Pooja, and I know she always speaks with extreme clarity. So over to you, Pooja.
Thank you very much, madam, for the kind introduction. Good afternoon, everybody. I would also like to thank Voice of Healthcare and Cipla Diagnostics for arranging this webinar. Dr. Raki, you will have to stop your screen share so I can start mine. Yeah, thank you. All right. So, is my screen visible, ma'am? Okay. So, good afternoon, everybody. And the topic that is allotted to me is SARS-CoV-2 variants and diagnostic tests. I'm Dr. Pooja Dalwari Gumaste. I currently work with Zavje Medical Services Private Limited. So the overview of my presentation will be structure of virus and occurrence of mutants, classification of the variants, variants in circulation in India, phenotypic effects of key mutations. Because we will know that there will be some mutations which will have an effect, there will be some mutations which will not have any effect. Public health risk posed by the variants, impact of variants on current method of diagnosis. So if we say there is alpha, beta, delta, will those variants be detected by our current diagnostics or we will miss those cases? Impact of these variants on public health control measures, newer test options for routine diagnostics and utility in field. We have seen that a lot of new tests are available, though all of them are not approved by IVD or DCGI in our country, but yet awareness will be very important for all of us. Genomic surveillance strategy and methods, and a couple of takeaway points. So we all have seen this structure, but again, I would like to remind everybody. So towards the 5' end, we will see we have all non-structural proteins. Towards the 3' end of the virus, you have all the structural proteins. So 2/3 of the genome is non-structural, 1/3 is structural. This virus has some proofreading function, which means that it will not mutate as fast as the other viruses like influenza or norovirus. Yet the rate of polymorphism is average 2 polymorphisms a month. So in view of this information, we are aware what we are dealing with. Every month, at least 2 mutations will be occurring in the genome. So where are these mutations? So ORF1, A, 1B, and S. These are the most common targets of the mutants, then followed by N. Okay, so why is it important for us to know this, spread of the mutants across the genome? So our selection of kit depends on targets. And if we are aware what targets are prone to getting mutated, we know what combinations to use. Classification, I'll not bore everybody with these classifications, but at least mainly there are 3 types of classifications: GSED clades, next strain clade, and pangolin lineage. So usually we are referring them to as alpha, beta, delta, but as microbiologists and in scientific fraternity, we deal with this nomenclature, B.1.1.617.2 and so on. Here, this is GSED classification, which is depending on the amino acid change. Say, for example, this S clade. So the mutation is at ORF8 and L84S. So the amino acid is replaced by S. So because of that, the nomenclature is given. Next strain is based on temporal dating, and pangolin is phylogenetic assignment of named global variant, global outbreak line lineages. From all these mutations, I have circled one, which is SD614G. This is a very important mutation. Why is it important? Because this is occurring in receptor binding domain of the spike gene. So what happens with this mutation is the RBD opens up like a flower. And from G clade onwards, you will see that there is consistently the mutation is present, which means that the transmission is going to be more than the previous viruses. Okay, so this mutation we will be referring to a lot in coming slides. So WHO has classified the variants into 3 categories: variants of concern, variants of interest, and variants under monitoring. So what is a variant of concern? The definition is anything which is which has demonstrated to be associated with increase in transmissibility, which has demonstrated increase in virulence, and which has demonstrated decrease in effectiveness of public health measures and even vaccines. So variants of concerns are something where you have already demonstrated that this variant is supposed to do this. Variant of interest is something where you are suspecting that this strain could do this. And variants under monitoring are the ones where you have the possibility that this could happen, or you are just predicting. There is no evidence. Okay, so we will be monitoring those trends. What are the current variants of concerns? There are only 4 current variants of concern: alpha, beta, gamma, and delta. We will be talking about delta in detail because this is the most common uh, variant as of now in our country, B.1.617.2. Okay. So previously they were categorized as per country where they were isolated, but now that nomenclature is no longer used and only alpha, beta, gamma, and delta is being used. Variants of interest, these variants have genetic changes that are predicted. Okay, sorry. They are predicted to cause changes to virus transmissibility, severity, and may cause immune escape. Immune escape meaning your vaccines response, whatever antibodies are generated will not work. Your monotherapy, monoclonal antibodies may not work, and your cocktail therapies may or may not work. Currently, there are only 2 variants of interest, lambda and mu. So previously there were many, if you remember, there was a big list that came in newspapers, kappa, iota, eta, epsilon, but all of these are now variants under monitoring. There were 2 VOIs which are now not even variant under monitoring, zeta and theta. So currently only 2, lambda and mu. Variants under monitoring are just suspected. So we should remember, so these 3 categories are different. One is concern, where you have demonstrated that this happens in this variant. One is interest, that yes, this mutation can cause this and we have to watch over it. And one is only monitoring. We have to monitor whether it is going to be of any public health significance. So what are the criteria? How do you pick up that, okay, this could be a variant? So at all levels, everybody can help identification. It's not only lab. So one is risk of infection is one of the criteria, that is transmissibility. Then you have the disease course. So as clinicians, a lot of times as a standalone lab, we also depend on clinicians to tell us that is a particular case causing more clinical severity than a routine COVID case. So such cases are also eligible for sequencing. There are different criteria for sending samples for sequencing, and this also is one of them. That if you have a patient who has out of proportion illness or some new presentation, then those samples are eligible for sequencing. So again, that severity of the disease. One is your RT-PCR target failure. In April, most of the labs who were using S-gene-based assays had faced that they were having S-gene dropouts. And that was the time when it was pointed that it could be a very new variant. So as a lab, it is our duty to monitor a single, any gene being dropped out, then your routine assays. So currently, if you are using an assay which has only N and ORF, you see failure of any one target. If you retest and again you see a single gene pickup, usually we ignore single gene pickups, but sometimes if we consistently get a single gene at a good CT value, those samples are also eligible for sequencing. So as microbiologists, we should monitor such samples and speak to referral lab. I have always exploited this option and spoken to madam about every single unusual case that we get. Then neutralization. So the antibodies that are generated by vaccines should be able to neutralize the virus. So if it is not getting neutralized, then those particular samples also need sequencing. So these are methods which WHO recommends for investigating and characterizing the emerging variants. Now variants in circulation in India. In Indian context, we can see that we have seen such huge number of cases, over 39 lakh. We have seen 4,50,000 deaths. And even on 10th of October, there were 21,000 new cases reported. So yes, this is a question all of us are being asked. Is this the end of the pandemic? And is the disease becoming endemic? So as of now, it is very early to say, because if we say that it is endemic, probably public health control measures also will lose the vigor that they have right now. So it is too early to say that it is end of the pandemic. We are still in middle of the pandemic, and we should observe all the behavioral precautions that we have been. So we'll just go month by month. This is data from GSAID's website. In March, you will see that there were a lot of variants in India, and Delta was only 7%. In April, that 7 became 56. In May, it became 95. In June, it became 95, July 98, August 96, and September, less sequences are uploaded, but it is 100% delta. So why I'm sharing this is that all the cases, maximum cases that we are having in the country right now are of the delta variant. So since it is the most common variant, it deserves a little bit of more attention. This is a very good study done by ICMR, and where they demonstrated the host and pathogen, pathogenesis in Syrian hamsters. So what they demonstrated mainly was that disease severity of Delta was slightly higher. They also demonstrated that the neutralizing antibodies, which were produced, Delta as compared to Delta, Beta was evading the immunity more than Delta. Okay, so why are we talking about Delta variant again? It is the most dominant circulating strain. It has increased replication and enhanced entry. The secondary attack rate of this variant is very high as compared to alpha. Evidence shows that delta generates a broader neutralizing response and is not as immune invasive as beta. So if you have a choice of getting infected with delta and beta, then probably delta is a better choice. No significant difference in viral RNA shedding among different variants. There is no difference. We can't say that if I'm having delta, I will shed more virus. So that is not the case. There is reduced neutralization by monoclonal antibodies and convalescent sera, but it is less as compared to beta. And we have, studies have shown that neutralization titers among Covishield and Covaxin recipients is lesser with the Delta variant. And probably this was the reason that we had a huge number of breakthrough infections, even in fully vaccinated individuals. Okay. However, this should not be a negative point against vaccine, because even in this population of breakthrough infections, there were very less patients who actually progressed to having severe illness and mortality. Yeah. This is a very lovely study where Madam is also one of the co-authors, epidemiological analysis of SARS-CoV-2 variants from different regions of India. So here what they showed was that the northern part of the country was fully under GH clade, and southern part of the country was under GR clade. And they wanted to say that there was increased number of variations within very short time frame. So this was suggesting that the virus is evolving, and it could be a step towards enhanced host adaptation. Okay, now phenotypic effects of key mutations. We will not go through the table, but let's just have a look. Transmissibility wise, gamma is the least transmissible, delta is the most transmissible. Antibody escape, alpha is the least and beta is the most. Okay. So public health risk, why are we talking about the variants and what are the risks they would impose? Increased transmissibility, it will cause more severe clinical course. You may not be able to detect the variants by diagnostic assay, hence monitoring will be required. Your variant could escape natural or vaccine-derived immunity. So your vaccine-derived immunity, if it is compromised, you will have breakthrough infections. And if your natural immunity that you developed after past COVID is compromised, you might have a reinfection. So these are the pointers to look for. And there could be decreased susceptibility therapeutics. We are seeing that a lot of patients are administered monoclonal antibodies, cocktail therapy. So in view of variants, the therapies may have decreased susceptibility. Now, what effect will these variants have on our current methods of diagnosis? So when you're talking about a COVID patient, you have n number of modalities. My colleague Rakhi had touched a lot of things. So we will not repeat those parts. We'll just skip to the important parts. So in which way these variants are going to affect our diagnostics, right? RT-PCR, our immunoassays, our lab, sensor-based technology, we are not using in India, so will not be very relevant, but we'll speak about it. Electron microscopy sequencing, rapid antigen test, and CRISPR-based assays. We will not be covering virus isolation because that is a test which is not used in commercial settings, so we'll omit it. So what will be the impact? Will our choice of specimens change? Will swab-free collection methods like saliva and mouthwash be more practical? Will our extraction-free protocols be the future? Will point-of-care tests be affected by variants? How do we choose our kits? Use of variant analysis kits, and what's new with rapid antigen test? Biosensors for COVID, and is there any other application of sequencing other than surveillance? So how do we choose our kits? I will answer the question here. You should at least have 2 genes from most conserved regions: spike, envelope, nucleocapsid, RDRP, and ORF. It should be a mix of these, at least 2 targets. Okay. So main question that as a microbiologist we are asked is, there are so many options of kits available where you can have a swab-free collection method. Then why not switch to them? So this is a question which is in practical and private labs asked a lot, because it helps them save manpower. It helps them make it more available and accessible for patients. So in the next slide, I will just cover what and why we should stick to our current sample collection methods. There was a study which says that, so here in this study done by Kuldeep Sharma et al., they compared all the specimens, and their main finding was the last specimen to become negative was the combined oropharyngeal and nasopharyngeal swab. And the sample which had the lowest CT value was also that, which points that the posterior pharyngeal wall is the primary site having highest viral load. So why I'm pointing out this is that in view of all specimens also, we should still stick to our nasopharyngeal and oropharyngeal swabs. And the reason is that the posterior nasopharyngeal tract is having a very high viral load. Okay. And there was a study where they had used saliva for COVID-19 screening. So when you have widespread tests to be done, big refugee camps, or a huge number, and the system is overwhelmed, you're not able to arrange for collections for so many. In such situations, probably saliva will be a very good specimen of choice. So if we go from swab to swab free, we should be aware. So change is always good, but we should be aware of why we are making the change and why we cannot make the change. Pros, we all are aware: convenient, simple, painless, reduce wait time, no PP, easy collection, etc. Cons, we should remember, most important thing is that saliva is where the virus ends up before being transmitted. It is not where it is actually growing. So scientifically, it is not a direct test of infection. Okay. Secondly, the contents of saliva can be influenced by the method of collection, degree of stimulation of salivary flow. And if you have a little bit extra mucus in your saliva, then your chances of detection will go down. So if you see, there are different literatures, they have said saliva is as sensitive as nasopharyngeal, saliva is more sensitive. So it depends, because while you are collecting saliva, there is a lot of variation in techniques. Okay. Possibility for degradation of salivary proteins due to presence of proteolytic enzymes in the saliva. And how do you preserve these specimens? Because according to your national guidelines, according to our local guidelines, we have to preserve specimens for at least 6 months till we get our ILC results. So will saliva be able to produce reproducible results? Will saliva be able to, pass that QC? So we should remember all these points while we are thinking of alternative specimens. Possible utility: epidemiological control and self-surveillance. It can facilitate widespread testing when there is requirement. And the literature has shown that at least half an hour fasting before saliva collection can help us increase the concentration of RNA. If you get a positive test from saliva, nothing like it, go ahead and treat it as a positive case. But if you have a negative test, we should do retesting in view of clinical picture. Okay, so if you want to switch from swab to swab free, please keep in mind that this will be certain challenges that you will have to deal with. Immunoassays, my colleague has covered, so I will not touch upon a lot, but here I will just say that there is no true neutralization assay available in market. A lot of assays are being marketed as neutralization assays, but they are not neutralization assays. Okay, ideally neutralization assays somewhere where you are exposing your serum, your sera of the patient with live virus and seeing whether it is able to neutralize. So which is not practically possible because it will require biosafety level 3 and beyond. So what is an alternative option to actually identify neutralization antibodies? It's called pseudovirus neutralization assay. It's a alternative method which we can use where a real virus is not used. It's less infectious and you can use it in biosafety level. So my like all colleagues, I would like to say, don't get flown away by the word neutralization. And actually, there are no true neutralization assays available in the market as of now. Point of care tests, there are a lot of options available in the market. There are a lot of options available in India. most commonly my colleague has covered, ID now and gene expert, so we'll skip this part as well. But what will be the impact of the variants on the POCTs? So FDA had analyzed all the POCTs, and what they have said is any test which has a single gene, Acula, Eplex, SARS, all these were given, a little. So none of the tests are affected as of now, but we have to monitor these tests which have single genes, because if there is a mutation, you might miss diagnosis. So you should be aware of the effect of variants on the existing POCTs. So with the rapid antigen test, what's new? Nothing much. There is a fluorescence-based lateral flow antigen test developed, which says that the sensitivity is 93.9 and 100% specific. What we should be aware of, there are certain mutations in the immunodominant epitope of N gene, T205I, D399N, and A3760 and M241L. So these mutations will not be, if there is a mutation like this, your rapid antigen will not pick up the case. In such cases, RT-PCR will come positive, but your RAT will not pick up. So such cases should be prioritized for sequencing. You have a negative RAT, clinically, patient is symptomatic and your RT-PCR is positive. So such cases should be sequenced. As of now, there are no reports of reduced performance of RAT in detecting any variants of concern. Okay, here this slide I had selected so that we could just compare, different assays and their limit of detections. So we are all aware that ID now has 129 copies, and all other kits are very sensitive. Now there is a technology which is not exploited in our country, which is CRISPR-based technologies. And if you see, the sensitivity of all the assays is less than 10 copies per microliter. So when we're talking about recent and new diagnostics, CRISPR is something which is validated by ICMR for being used, but it is not utilized as much in field. RT-LAMP, my colleague has covered, so I'll be skipping it. CRISPR-based assay, word about Sherlock detector. So I'll just take one slide on, sorry. Okay. So in the later part, I'll cover Sherlock a little bit. And then there is sensor-based technology. As of now, no sensor-based technology is available for use in India. There is no approval from Drug Controller of India. But one very promising technology is electrochemical biosensor. There are various types of sensors, if you see. Electrochemical, electronic, physical, optical. We will not be able to cover all, and it will not make much of a sense because we don't have these technologies available with us. But only, I'll cover a little bit of electrochemical and little bit of meta sensors. So why we are covering electrochemical is that you can seamlessly implement it into your existing system. The electrochemically active labels are more durable than your dyes, CIFAM, cyclodifam, all these. They will detect the genes at a concentration of as low as 1 copy per microliter. So as and as cases become less, we would want to have more sensitive tests because we don't want to miss out on a single case. The difficulty of the integration of PCR with electrochemical systems still creates formidable challenges in accepting this as a commercially adaptable system. Okay. So now metasensor based technologies. What do we do here? There is a plasmonic surface. So specific SARS-CoV-2 antibodies are immobilized on that chip, through which you will pass your sample, and whatever intact coronavirus particles are there, they are going to bind and lead to plasmon resonance. And these changes could be optically measured using a sensing system. Limit of detection, again, only 30 viral particles. You can use this technology for quantification also. It's very high specificity, low cost, and it is very scalable. So these two technologies could be exploited in the future. As of now, to be very clear, nobody is using them. Okay. So Sherlock, I wanted to cover because the principle of Sherlock is isothermal nucleic acid amplification and Cas CRISPR-based detection. So what happens is a person is given a container to spit saliva in. Once they spit, it is filtered and the sample is prepared in this chamber, and on the cellulose waste filter, you will get the RNA. Once you have this cellulose waste filter, it is kept into a direct reaction chamber where you will have Sherlock reagents ready, and this filter paper will go inside, and then the reaction will happen. you will be able to read the reaction visually or with the help of your smartphone. So this technology is very useful because they have adapted it to diagnose COVID as well as detect variants of presence. So if you see here, this small picture, if there is no COVID, both the tubes will show no fluorescence. If only one tube shows fluorescence, you have a non-variant COVID. And if both tubes show, fluorescence, you have detected a variant. So this is a test which I feel has a lot of potential, and it has already proven its worth in Zika and dengue virus testing. So we could sort of exploit this in places where RT-PCR is not feasible. Feluda was available. It's again a CRISPR-based technology. It is like a UPT. You just have to read it. So very, very usable in all settings without having need of any high-end equipment. Genomic surveillance. So we all know the advantages of genomic surveillance. So how is genomic surveillance done in our country? There are two types of sampling methods. You have a randomized sampling method and a fixed sample. So in our country, fixed samples are being sent from all sentinel sites. And there are certain criteria which are conveyed to private labs, clinicians, physicians, that if your patient is fitting in this criteria, please send the sample for sequencing. It's our role as independent laboratories to be in loop with referral lab and follow these guidelines and send relevant samples for genome sequencing. The requirement of genome sequencing is immense, is very immense, because you will not know what is happening and you might be using kits which are not able to pick up those variants. So it is very, very important that, periodic genomic surveillance is done. Also, it will help you gauge the effectiveness of public health measures. So genomic surveillance guideline is shared by WHO, and we all should do our part in sending those samples. What samples are to be sent? Direct sequencing is done. So you are preferably sending respiratory specimens. One more reason to think about oral fluids and mouthwashes is that there is variable detection of RNA from these samples while they are doing sequencing. So since we are still at a point that we will need periodic sequencing, we will not take a chance of, take a sample which are suboptimal or maybe, not adequate enough for sequencing. There are a lot of platforms which are available. There are pros and cons of each platform: Sanger sequencing, Illumina, Oxford, Nanopore, and Torrent. WHO recommends that definitely there are a lot of advantages and disadvantages of each technology, but whatever technology is available, sequencing should be done. There is one more potential of, environmental surveillance. You could use wastewater. A lot of countries like Denmark, Australia have been doing. So they periodically take water samples, wastewater samples from different localities and do PCR from those and see what variants are there in circulation. Say, for example, you identify an area where there is a lot of circulation of a particular VOC. It will help you design public health strategies, to go ahead and do what actions need to be taken. So the takeaway points at the end, I would like to say that we should all stick to our basics while evaluating new technology. Rigorous validation protocols and a high sampling rate would determine whether these devices are capable of use in long run. And we are all aware that more the virus circulates, the more opportunities it has to change through natural evolution. So behavioral measures, using of mask and all other behavioral measures will still stay important. Any technology for being available for commercial use for public need appropriate approvals. Before selection of any kit, any product, please see that it is CIVD, it is DCGI, it is ICMR approved. Oropharyngeal and nasopharyngeal swabs are most preferred clinical specimens despite various other specimens available. If we all know, we have had H1N1 from 2009 in our country, but still the choice of specimen has not changed. So from our previous knowledge of respiratory viruses, we all know the specimen of choice is OPS and NPS swabs. By now, we are aware that genetic variants arise regularly and false negative results can occur. We should be aware that we should use kits only those which have multiple genetic targets. We should repeat testing with a different molecular test if COVID-19 is suspected even after receiving a negative result. We should exploit available genomic sequencing options and send samples to referral lab. This way, we will be able to stay ahead in top of the mutations. Now, antigen tests. WHO has said that rapid antigen tests are reliable only in settings where prevalence is more than 5%. I think we are at a lesser prevalence now. So rats should be used with utmost caution. Okay, that will be it. These are my references. And at the end, I would like to say that everybody gets so much information these days on a lot of platforms that we all sometimes tend to lose our common sense. And I wish all of us continue to, have our common sense in place before jumping on to new tests and technologies. I thank everybody for their kind attention. Thank you.
Thank you very much, Pooja, for this lucid, comprehensive, informative presentation. I also learned a lot about variant diagnosis, but I would like to just add two things.
Yes.
One thing is at the government institutes, especially the VRDLs of ICMR, we have got the variant PCR, which is a multiplex PCR from NIV. Right. So, in fact, I must say that private labs have a very important role in identifying the right kind of samples which need to go for sequencing or for a variant PCR. Here, I would like to share my own experience with Pooja in the month of, say, February, March, where she observed a cluster of cases from a defined geographic area. And I truly appreciate her efforts in, going the extra mile in calling us up and trying to tell us that this is the scene, and that time we were not doing sequencing. So we, in fact, got it sequenced in NIV, and the results were, directed towards the UK variant being rampant in Mumbai. So everybody has the role to play, and what really COVID has taught us is the best way forward is networking. We need to network between all of us, between the government as well as the private labs. And today, in fact, we are getting so much of support from the private labs by way of sentinel surveillance, because there is a mandate that almost 5% of the samples need to go for genome sequencing. So the municipal corporation has been collecting samples from many private labs and sending it for sequencing. And since August, we have been doing the whole genome sequencing at our lab in Kasturba Molecular Lab at Chinchpokli. So I would also, if time permits, I don't know who's taking care of the time. I just want to share our experience with genome sequencing. Genome sequencing is definitely for surveillance. It is not for diagnosis. Yes, if you have see, in diagnosis, the most important thing after Rakhi's presentation, what I said, I would like to reiterate that it is the pre-analytical step of appropriate sample collection, because that is one area where we are not checking the competence of an individual, where even an NABL lab is falling short of checking the competence, because we have done a study by which we have in fact seen variations in sample collection contributing to drastically different results. So this is one area which we definitely need to focus and strengthen. Now, the other thing with reference to genome sequencing, we had a very so genome sequencing is like a suspense thriller, Every time my samples go into the sequencer, I'm like waiting for the results, because, I'm just waiting. Am I going to get a new variant? What am I going to understand about the samples which were collected? So when we did it in August, we had samples from January onwards. And what we observed was in Mumbai, between January to May, like before the Delta came, around April. So January, February, March, few samples of April and May, we had the Kappa variant. Now, the Kappa variant is the variant of interest, and it is B1.1.671.1. It is 617.1, whereas 1.617.2 is your delta. So, Kappa was contributing to mortality. Now, this is a very strange observation we saw, because if there is mortality, then the virus cannot spread from individual to individual. And as microbiologists, we all know that the pathogen takes a form and shape by which it is extremely transmissible because it wants to survive. So the mutation from Kappa to Delta led to excessive transmissibility but less lethality. So this was our observation through genome sequencing, that January to March, we found a fair amount of Kappa variant, but the Delta variant from April onwards just swept across the country and was wreaking havoc. So we have understood the evolution of the virus. And in our third round of genome sequencing, we have again got a variant of interest, and we will be sharing the results with the center very soon. The only thing which we have observed is that this variant has not caused any severe manifestation clinically, or it is not transmissible. And within the family also, the contact tracing, it is not transmissible. So every area of molecular work, molecular diagnostics, surveillance, we have strengthened. We have taken the opportunity of COVID and we have strengthened. And as a country, I think in terms of diagnostics, we have really done very well with so many labs doing RT-PCR, and it is commendable, the efforts of ICMR in networking with all the country labs. So yeah, a word about the sensor-based diagnosis, I would just like to add that still there is no clarity about sensor-based diagnostics, because the DCGI is very clear that once it is approved, it's actually getting a little difficult to get CE-IVD approval these days. I don't know the reasons, but many of the sensor-based technologies have not got approved by CE-IVD, and therefore the DCGI is not even taking these requests. So though we have really come a long way, there is always a scope of improvement. And my only take-home message to all the labs who are participating in today's seminar is that please network with your government labs. Please maximize your strengths. Everybody comes with so much of strengths. And today I have realized that if we have to do any project, everything is possible because we have a team now, and our strength are all the labs in the city. And with perfect networking, I think we can really achieve. It's no longer a dauntable task. Everything can be achieved. Thank you very much. I'll be free to take any questions and any questions to Dr. Rakhi or Dr. Pooja.
Hello, madam. There are some questions in Q&A. The first question is RT-PCR or TrueNAT, which one is better?
Who wants to take the question?
Can I?
Yeah.
Okay. So RT-PCR or TrueNAT, basically they both test the COVID-19 on the same platform. There is just a difference in the instrument. Basically, the technology remains the same. So even ICMR says that 2 positives by TrueNAT can be considered as 2 positives, and we did not go for a RT-PCR testing. So if you are using a multiplexed TrueNAT, yes, then they both are the same. But if you are using for a single gene TrueNAT test, then yes, we will have, then RT-PCR will be better, because it usually has 2 gene or 3 genes. Nowadays, all the kits of RT-PCR are having 2 or 3 genes now. I hope that answers the question.
Pooja, do you want to add something?
No, ma'am, that will wait.
So I would just like to add, because we have experience with TrueNat as well as RT-PCR. So in our experience, the biggest problem with TrueNat is that any RT-PCR 29 and above CT value is not picked up by TrueNat. So the sensitivity of TrueNat seems to be less, because what happens is, I tell you this, accidentally we found out. Because many of our healthcare workers, whenever they have symptoms, and since TrueNat results are available in 2 hours, they immediately give their swab and get a negative sample, and simultaneously they give it for RT-PCR. So when you have 2 samples given at the same time, collected at the same time, and tested by 2 different platforms, you come to know the differences. So what we have seen is that 29 and above, somehow TrueNat does not pick up the results. So this is our observation. And there is one more thing I would like to add, since there are a number of private labs. Another thing which we have seen is that the extraction kit which you use, again, is very critical in the right results, because we have seen a variation of results with differing extraction kits. So that is some sort of an in-house validation you may possibly have to do when you start doing your testing. Any other question?
The second question is, what are the different type of TrueNat assays available in India?
May I take this question? Yeah. So in context of COVID, there are 2 types of assays. One is e-gene, and then if your e-gene comes positive, you again do a single plex for RDRP. And one more assay is available, which is called multiplex, which has E and ORF both. So these are the options that TrueNat offers for SARS-CoV-2 as of now.
Okay. And the last question is RT-LAMP technology superior to RT-PCR? And how often are we using this technology?
I'm not aware of any labs using RT-LAMP. If they are using, please come forward and let us know. As of now, we have just got one kit for validation, because our center is validating newer kits also. So we are validating an RT-LAMP kit on saliva sample and comparing it with RT-PCR. So once it is made available, we will let you know. The other thing about TrueNat, what I would like to say is that there is no ILQC as such available now for TrueNat, at least through ICMR. At least for RT-PCR, most private labs, around 50 private labs, are sending us samples for ILQC. But for TrueNat and CBNat, both the platforms, as of now, ICMR does not have any ILQC in place. So, this is just a word of caution. Are there more questions?
No, madam, there are no more questions.
Okay, so if there are no more questions, happy Dussehra to all of you, and let's all enjoy this festive season. But please be safe. Don't bring down your guard. Pooja has already told you that the variants are all in and around, and we are diagnosing them. So let's enjoy the festive season by just being safe. Thank you very much. And I thank Voice of Health for this opportunity.